Good afternoon to our East Coast participants and good morning to our West Coast attendees. Thank you for being here. It's wonderful to have hundreds of you joining us from across the country to discuss this important topic. Welcome to our webinar, Paradigm Shift in Prostate Cancer Disease Management, brought to you by Zero, the End of Prostate Cancer, in partnership with Halo Diagnostics. I'm Shelby Monier, Vice President of Patient Programs and Education at Zero, and I'll be your host today. Thank you for being here and joining us. Before we start, I'd like to go over a few housekeeping items. First, today's webinar is being recorded and will be posted on our website, zerocancer.org, early next week. As soon as the webinar closes, you'll see a link to a survey, and we would love for you to participate so we can get your feedback on this educational event. On Monday, you will also receive an email with a link to the recording and the survey as well. In addition, this program is being live streamed on Facebook and our website. For those of you not already familiar with Zero, the End of Prostate Cancer, we are the leading national nonprofit with the mission to end prostate cancer. Zero advances research, improves the lives of men and families, and inspires action. We're building Generation Zero, the first generation of men free from prostate cancer, through our National Run Walk series, education and patient support programs, and our grassroots advocacy efforts. If you are new to the Zero family, we welcome you. I want to thank Dr. John Feller, Bernadette Greenwood, and Dr. Jeffrey Herz, our three featured speakers. Thank you for sharing your time and expertise with us for this webinar, and thank you to Halo Diagnostics for your support. Here's a quick overview of our agenda for the day. After I make introductions, our speakers will present on new developments in prostate cancer, the importance of PSA in early detection and diagnostics, treatment, and survivorship, as well as the promise of focal therapy. After the presentation, we will have time for some question and answers. We'll then conclude our webinar with me sharing some information about Zero's free patient support and education programs. To make this next hour as interactive and helpful as possible, I encourage you to ask questions. Please type your questions in the Q&A box, which is located at the bottom of your screen. You can also ask a question anytime, and we will get to them at the end of the presentation. We'll get to as many questions as we have time for, so we look forward to answering any questions that you have throughout the presentation. Next, I'd like to get started with a few introductions. First, it's my pleasure to introduce Dr. John Feller. Dr. Feller is an assistant clinical professor in the Department of Radiology at Loma Linda University, an assistant clinical professor in the Department of Radiology at Riverside School of Medicine. He has lectured worldwide on orthopedic, prostate, and body MR imaging. Dr. Feller started and leads an MRI-based prostate cancer detection and focal therapy program at Halo Diagnostics, which has provided care to over 3,000 men. Our next speaker is Bernadette Greenwood. Ms. Greenwood earned her postgraduate certificate in imaging at the University of Edinburgh. With 30 years of experience, she conceptualized and developed a patent-pending focal laser interstitial thermal therapy of prostate cancer with transrectal approach under MRI guidance in 2009. She lectures frequently on topics related to oncologic imaging and is an internationally recognized expert in prostate MRI and MR-guided intervention. She is currently pursuing her PhD and recently accepted a clinical instructor appointment at UC Riverside School of Medicine, Department of Internal Medicine. Our third speaker is Dr. Jeffrey Herz. Dr. Herz is a board-certified urologist who currently practices on a limited basis at Halo Diagnostics, focusing on the prostate program. He has been practicing urology for the adult and pediatric community for more than 40 years. His expertise has gained him honors as one of the top doctors from 2005 to 2018 in the Palm Springs Life magazine. I'll now turn it over to Dr. Herz and the Halo team. And once again, I want to thank your team and Dr. Herz for joining us. Dr. Herz, you now have the floor.
Thank you very much, Shelby. Hello and welcome to everyone. I hope by the end of this presentation, you'll have a great understanding of the current state of the art in diagnosing and treating prostate cancer. We'll see how far we've come and the tremendous advances that have been made over the years in diagnosing and treating prostate cancer. But in order to understand and appreciate where we are today, I think it's instructive to look at where we've been and where we have come from. And as a board-certified urologist practicing for over 40 years, treating thousands and thousands of patients with prostate cancer, performing radical prostate surgery myself, referring thousands of patients for radiation therapy, treating thousands of patients who've had recurrent prostate cancer despite definitive therapy, and thousands more metastatic or prostate spread. Over the past 40 years, I've experienced a tremendous breadth of knowledge in and I've seen tremendous progress in prostate cancer therapy. When I opened my office doors in 1980, any patient who walked through that door with a diagnosis of prostate cancer was quite literally on their way to the grave. There was very little we could do to treat prostate cancer, and that's generally because by the time we were able to recognize prostate cancer and diagnose it, it had already spread. We were unable to, in most cases, diagnose prostate cancer early enough when it was organ confined to allow and attempted cure. And the treatment for those patients was very limited. The only treatment on our shelf in those days essentially was hormonal manipulative therapy, androgen ablation therapy, removing testosterone. And in those days, and in the 80s, that was generally done with surgical castration. There was no chemical castration available at that time. And that was essentially not curative, but would help to put the cancer, in many cases, in some remission, maybe for 2 or 3 years. But ultimately, those patients generally succumbed to prostate cancer, which was a long and usually painful death. Everything changed in 1990 when serum PSA levels became available to us and were mainstreamed, and with the simultaneous development of prostate ultrasound examinations to allow urologists to perform transrectal ultrasound guided biopsies of the prostate in an office setting. Previously, diagnosing prostate cancer was done by biopsy in the operating room under a general anesthetic and with large bore needles, really developed for biopsy of liver and not for the prostate. So this was a tremendous advance. The biopsy cores were smaller and the procedure was a lot more favorable for patients. And so with PSA testing, we were able to attempt to find prostate cancer at an early stage when we could intervene and potentially cure the disease. Serum PSA, or prostate-specific antigen, this test is not a perfect test. And in medicine, very few tests, if any, are perfect. And so it's not merely the absolute number of PSA, the value that we see on a single laboratory test, that may be important, although that is in itself, but it may also be several points along the curve, several PSA determinations over time that can help us find early prostate cancer. At some point, the U.S. Preventive Health Task Force criticized PSA testing as non-accurate, and in a sense that was a disservice to patients, because we found that PSA testing was in fact extremely valuable and necessary, but like any other test in medicine, it had to be interpreted properly. And if it was, it became an amazing tool to find prostate cancer early. So through the 90s, we were using PSA determinations and performing TRUS, or transrectal ultrasound guided prostate biopsies, in the office. Today, 20 to 30 years later, we can look back on those days and be somewhat critical and say those were pretty primitive things that we were doing then. TRUS prostate biopsies are really not focal biopsies, but are more regional biopsies into prostate regions. Still better than what we did previously, but not very accurate. With further technological development, magnetic resonance imaging now can detect prostate cancer in a very accurate fashion and display it on an image so we can see the actual prostate cancer lesion, and biopsy through the MRI in-bore system to the lesion itself. And in fact, not only the lesion, but the most active portion of that lesion, to get a true pathology specimen for determining prostate cancer in our patients. So this tremendous breakthrough in diagnostics has occurred over the past several years, and allows a much more accurate determination and diagnosis of prostate cancer. In fact, it is so accurate that the European Union has recommended it as a procedure to be done prior to obtaining prostate biopsy. And the American Urologic Association also recommends in their guidelines that prostate MRI examinations be performed prior to prostate biopsy. Essentially, these tremendous breakthroughs in diagnosing and treating prostate cancer have also been paralleled by the development of new treatments, new chemotherapy, excuse me, new chemotherapies, immunotherapies such as Provenge vaccine, therapies that are being developed and have been developed. So we have a lot more arrows in our quiver to treat prostate cancer once it's diagnosed. This has been extremely beneficial, particularly when you look at the prostate cancer survival numbers, which now compared to prior to PSA testing days has dropped more than 50%, a 50% improvement in survivability. Treatments that I have myself performed with radical prostate surgery or radiation therapy are still being done, but new treatment options targeting focal therapy are also now available. And we see this trend in oncology, not just for prostate cancer, but also for other malignant tumors in terms of minimal treatments. So for example, whereas we used to consider breast cancer a very lethal disease and treat every patient with radical mastectomies, you find now over time we are doing many, many more lumpectomies, minimal types of surgery, and finding excellent survival in properly curated patients for those treatment options. In urologic terms, we see this also with renal cancer, where we used to just do radical nephrectomies, remove the entire for any kidney tumor, because renal cancer was a very onerous cancer. But over time, particularly learning from patients who only had one kidney for various reasons, and applying a minimalist approach to remove the tumor, we found that survival in those patients was just as good as survival with radical nephrectomies. And this has led to partial nephrectomies, or just removal of the tumor and leaving the remainder of the kidney to continue work and prevent the possible need for hemodialysis. And so this trend has also been seen in treating prostate cancer with focal energy. And Bernadette Greenwood and Dr. John Feller will be talking more about that advance that we are currently experiencing. So at this point, I think I'd like to turn the microphone over to Bernadette Greenwood. Thank you for your attention.
All right, as you can tell by my voice that actually this isn't Bernadette Greenwood, but this is Dr. John Feller. I'm going to actually jump in here and want to thank Dr. Herz for that historic context. And I'm going to be talking about the epidemiology and serum PSA, and then Ms. Greenwood will be addressing the multiparametric MR and the MR targeted biopsy, and then I will finish up things with an overview of where our MR guided laser focal therapy program is. So first of all, the scope of the problem of prostate cancer in 2020. Prostate cancer accounts for 1/4 of all cancer diagnoses, and 6 of the cases are diagnosed in men over the age of 65 years. After skin cancer, it's the most commonly diagnosed cancer. The average age of diagnosis is 66 years old. 1 in 9 men will be diagnosed with prostate cancer during their lifetime, which in the United States is about 191,000 patients each year. There are almost 3 million men in the United States currently living with prostate cancer. Unfortunately, in 2020, 1 in 41 men will still die of prostate cancer, which is about 33,000 deaths annually. So after lung cancer, this is the second leading cause of cancer death in the United States. If we look at risk factors for prostate cancer, age is important. It's rare under the age of 40 and increases in risk above the age of 50. A family history is important, particularly in first-degree relatives. And then ethnicity is important, particularly among our African-American and Caribbean men of African descendants. They're 1.8 times more likely to be diagnosed with prostate cancer and 2.5 times more likely not to survive the disease. The challenges of the traditional methods that Dr. Herz reviewed are listed on this slide. First is that screening with serum PSA historically had been associated with overdiagnosis and overtreatment of clinically insignificant prostate cancer. And by that I mean cancer that will never metastasize or take the patient's life, which is usually Gleason 3+3 or Gleason 6 or grade group 1 disease. Also, historically, following the serum PSA, we didn't have additional testing that would help the screening test. In addition, PSA is prostate-specific, but it's not prostate cancer-specific. So as a result, it can be elevated from benign disease like BPH and inflammation like prostatitis, and isn't just due to cancer. So there are some inaccuracies as a result. Next, the digital rectal exam that's performed by physicians in office. It turns out it misses at least 70% of clinically significant prostate cancers, so it's not particularly accurate or sensitive. These things combine to result still in 2020 in a delay in diagnosis of clinically significant prostate cancer. Also, the transrectal ultrasound-guided biopsy, also called a systematic biopsy that Dr. Herz mentioned, it can result in overtreatment of the clinically insignificant prostate cancers, and misses up to 1/3 of clinically significant cancers because the biopsy is done randomly. Both the transrectal ultrasound-guided biopsies and treatment of clinically insignificant prostate cancer can result in significant side effects. So we all know that whole gland therapy, for example, radical prostatectomy radiation therapy, can result in erectile dysfunction in up to 50 to 70% of patients, and urinary incontinence in about the 15% range. Also, the staging, the clinical staging of prostate cancer, which is an assessment of where exactly the prostate cancer has spread, is underestimated compared to the pathologic staging that we get from the surgical results in up to 1/4 of the patients. Next, about 25% of patients, so 1/4 of patients that are in active surveillance, meaning they're being followed by their urologist with periodic serum PSAs and periodic biopsies. 1/4 of those patients actually have higher Gleason score prostate cancer than has been detected previously, and really should be having definitive therapy for their cancer and not just active surveillance. Finally, there's the problem of biochemical recurrence. These are patients that have been previously successfully treated for their prostate cancer, but then their PSA starts coming up. And this is almost always due to a recurrence of the prostate cancer. It's just that historically we had trouble knowing if that recurrence was locally in the prostate or if it was distant metastatic disease. So what do you folks as prostate cancer patients or potential prostate cancer patients care about? You want us as clinicians to detect clinically significant prostate cancer. You don't want us to find insignificant cancer because it just worries you and puts you in active surveillance trials, spends money, has unnecessary side effects of active surveillance biopsies. So you don't want us to find that disease. You care about your quality of life. So you care about the side effects of the biopsies and the treatment. You care about us getting an accurate Gleason score. And the reason for that is it's the most important biomarker determining your therapy and your prognosis and what your survival looks like. So you want an accurate Gleason score. You care that we don't overtreat clinically insignificant cancer. Why? Because of those side effects that I mentioned associated with whole gland therapy. You care about the risks of treatment versus the risks of not treating. So remember, there's a lot of risk if you have clinically significant cancer that hasn't been diagnosed of not treating you. So we need to find that significant cancer and treat it sooner rather than later. And then finally, at a certain level, you care about the cost of the treatment overall to the healthcare system, but also the out-of-pocket costs that are associated with these treatments and active surveillance for you as a patient. There are also medical legal issues arising. Historically, medical legal lawsuits against clinicians related to delay in diagnosis of prostate cancer were mostly related to failure to perform a serum PSA or to follow an elevated PSA or to report that elevated PSA to the patient. But notice what is also starting to appear is failure to perform a multiparametric MRI of the prostate, because this is now part of the standard of care and clinical pathways in a patient who has an elevated PSA, as Dr. Herz mentioned, and this MRI is now indicated prior to any biopsy. Now, I'm a little bit of an amateur astronomer, and I love this Scrabble word, syzygy. This basically is an astronomy term that talks about the collinear alignment between three celestial bodies, like 3 different stars or 2 stars and the moon kind of a thing. And this is an example shown here on an ancient Chinese star map from 1000 BC. And I like to talk about the prostate syzygy that has occurred in the last few years. There are 3 things that have lined up that have really driven the paradigm shift that we're talking about today in 2020. The first is the emergence of a new type of MRI called multiparametric MRI that helps with detection of clinically significant prostate cancer and also does not detect insignificant cancer. We don't want to find it. We don't want to overtreat it. The second component of this syzygy is the development of new hardware and software solutions that allow us to do image-guided interventions. This includes MR-guided in-bore biopsies, MRI ultrasound fusion biopsies that we do with our urologist colleagues, and also MR-guided focal therapy. The third component of this thing that got lined up is an improved understanding of the natural history of prostate cancer, including the concept of the index lesion. This issue is that we know that prostate cancer is multifocal, meaning in more than one place in the prostate gland in 80% of patients. So that's why focal therapy was not developed over the last few decades. But now we know that the largest, highest Gleason score focus of the prostate cancer is the one that determines the prognosis of the patient and the one that drives what type of therapy the patient should have. So because we can use multiparametric MRI and MR-targeted biopsy now to reliably find this index lesion, now we can also use image guidance to focally treat that index lesion and not worry about the other lesions or other areas of prostate cancer that are clinically insignificant in the prostate gland, and do essentially an organ-preserving treatment approach similar to what's done with a lumpectomy and radiation therapy, preserving the breast of a woman that has breast cancer. So there are going to be three components to the clinical pathway we're going to discuss today. I'm going to talk about screening serum PSA next. Then Ms. Greenwood will talk about multiparametric MR and MR-targeted biopsy. The challenges I mentioned with the conventional, traditional, historic screening method was, as I mentioned, that it was associated with overdiagnosis and overtreatment of clinically insignificant cancer, and that an elevated serum PSA can be due to other things other than prostate cancer. I also mentioned that the digital rectal exam misses 70% of clinically significant prostate cancers, and this exam is shown here schematically on the right. The serum PSA has some other problems related to prostate cancer, and that is that at a threshold of 4, 15% of patients that have clinically significant prostate cancer actually have a serum PSA that is below that cutoff of 4. And even more commonly, 40% of patients who have a serum PSA above the cutoff of 4 never develop clinically significant prostate cancer. Their elevated serum PSA is due to something else, the benign prostatic hyperplasia or prostatitis. And this is where multiparametric MRI comes in to help us use this screening exam better. There's an old saying that a fool with a tool is still a fool. Well, we need to use this tool of the screening serum PSA better. So how do we use it better? Well, first of all, notice the data here in the upper left-hand corner that unfortunately only 13% of men between 40 and 54 have had a screening serum PSA, about 40% between 55 and 70, and about 45% of patients over the age of 70. So we need to do a much better job of reaching men with a screening serum PSA. What's the reason for that? There is very good peer-reviewed, published, and presented data that shows at least a 30% reduction in the mortality or the death rate from prostate cancer when screening with serum PSA is performed on a population. But when should we do this? It turns out there's very good data now that a baseline serum PSA between the age of 40 and 45 is very, very useful. After that, above the age of 50, between 50 and about 75, a screening serum PSA is indicated. This is particularly important in our African American men and also in men who have a family history of prostate cancer, especially in a first-degree relative. In addition, we also know that men who have BRCA1 and BRCA2 genetic mutations, so the genetic tests that typically we associate with breast cancer, if men are BRCA1 or BRCA2 positive, this germline testing puts them at increased risk of developing prostate cancer, also at a younger age and with more aggressive disease. So with that, I'm going to leave the screening serum PSA, which, as a summary, reduces the mortality from prostate cancer in at least 30% of patients. And now we're going to talk next about what multiparametric MRI does to improve this screening test. And with that, I'll hand the lecture over to Ms. Greenwood.
Thank you, Dr. Feller, and thank you, Shelby, for providing us this opportunity to share the advancements in prostate cancer diagnosis. So multiparametric MRI, for those of you who don't know what it is a combination of imaging sequences in MRI that provide very high detailed images of soft tissue anatomy. It's very effective for detection of clinically significant prostate cancer. And as Dr. Feller mentioned, often will not pick up insignificant cancer, which is a good thing. We combine it with serum PSA and derive something called PSA density, which is the PSA divided by the gland volume, which is a great prognostic indicator. And it's estimated that multiparametric MRI can increase detection of clinically significant cancer over other methods by about 50% and reduce the number of unnecessary biopsies by about 30%. Excuse me. So back in 2016 was the first time that multiparametric MRI was mentioned in the National Comprehensive Cancer Network guidelines, also known as the NCCN guidelines. And they stated clearly that multiparametric MRI followed by lesion targeting may maximize detection of high-risk disease and limit the detection of low-risk disease. And this does two things. It gets us in to detect cancer early and treat it properly, and it avoids the overdiagnosis and overtreatment of indolent disease. So in 2019, the American Urological Association updated its policy statement, as did the European Association of Urology. And pretty much the general rule of thumb is no MRI, no biopsy. And I would tell any man that I care about, don't ever let anyone put a finger, a needle, or a scalpel anywhere near your prostate until they've done an MRI first. The AUA policy statement now reflects, 1.1 million multiparametric MRIs of the prostate are performed in the US annually, and that's about 0.5% of all men. And when you look at the medical codes that are used for billing and reimbursement, it's currently the fastest growing code in the US. And it's growing at a rate of about 30% per year. It looks a lot like what breast MRI did about 10, 15 years ago. So now fast forward to the NCCN guidelines for 2020. Not only do we talk about performance of MRI and targeting, then we also include things like addition of biomarkers, companion diagnostics that will improve the specificity of screening and the MRI result. So we've got other tools in the toolbox beyond just MRI. So I mentioned mammography screening and breast MRI. Back in the 1990s, mammography screening set a precedent for men's imaging and prostate MRI. We talk about things like the manogram. We want men to be screened not only with PSA, but also with imaging. So between 1987 and 2015, women over 40 who participate in mammography screenings increased from 15 million women to over 50 million, 50. So from 15 to 50. And in the same time frame, the mortality rate for breast cancer decreased by more than 40%. So currently, 60 million men over 45 in the US probably need screening. And in 2010, per 1,000, 5.2 men received a prostate MRI compared to 13.5 per 1,000 men in 2016. So at this rate, it's anticipated more than 20 men per 1,000, about 1.2 million men are going to get prostate MRI in 2020, and that's a good thing. So I mentioned the calculation of PSA density, and we view it sort of as a safety net. The false negative rate for multiparametric MRI is something on the order of 10 to 15%, which, if you remember, Dr. Herz said random systematic biopsy can misclassify something like 30%. So this is an improvement, but it's still not perfect. So PSA density can be used as a sort of safety net. It's the PSA divided by the gland volume as derived from either MRI or ultrasound, and a PSA density greater than 0.15 nanogram per milliliter per cc is an indication for systematic biopsy if it's not been performed before. So, and then we always perform a multiparametric MRI-based follow-up to check for MRI progression. I mentioned companion diagnostics and tissue-based genomics. So as long as we're in biopsy mode and we're taking tissue to get the Gleason score, why not run genomics as long as we've got the tissue? So the goal for the genomic test that we use, we happen to use one called Decipher. There's a bunch of them out there on the market. We've evaluated about 7 of them, and we chose Decipher for biopsy for a couple of reasons. We like the clinical report that it generates, which is based on a 22 gene panel and gives a low, intermediate, or high risk profile. And we're able to do some research use only work with the tissue after the fact. So the goals of Decipher training and certification for doctors, which it's open to any physician that's ordering the test, is to ensure that doctors who order it understand the limitations of the test, to inform prescribers and patients the safe use conditions for Decipher, and to avoid missing clinically relevant development of metastasis. So this test isn't something that just comes out of the box and gets performed in a vacuum. Every doctor that's ordering it undergoes training and certification so that they understand what they're ordering and how to communicate the results to you. So let's take a look at multiparametric MRI in the active surveillance environment. So there's active surveillance, which is pretty much PSA annually, but then there's MRI-based active surveillance where we're doing MRI in conjunction with PSA. So this helps determine the best candidates to remain on active surveillance. And it's critical to monitor men who choose the approach so we can manage their disease and pick up progression and advancement of cancer or new lesions early before they become a problem. So 26% of patients in active surveillance who undergo MRI end up being upgraded to a higher Gleason score and get moved over to definitive cancer treatment. With that, I'm just going to summarize the message that I delivered earlier. Before you allow anyone to put a scalpel or a finger anywhere near your prostate, make sure you have an MRI performed first. Medicare, it's an easy procedure and provides a great deal of information from an imaging standpoint, as well as the PSA density. So with that, I will pass it back. Oh, pardon me. Oh, about MRI targeted biopsy next. Sorry about that. So we talked about the benefits and the merits of MRI. So this is a really nice little the reason why systematic biopsy isn't very helpful. The biggest problem is it could miss the lesion that we're in. Consequence was aggressive disease elsewhere. Another issue is we could skim the lesion and miss the most aggressive component. Random was an improvement for older strategies. It's not quite as good as MRI targeted. So the poke and hope methodology is something that we hope to make go away by using MRI targeting, because as mentioned previously, it undergrades Gleason score 30 to 40% of the time. So in addition to getting better histology or Gleason score, we're able to do these genomic tests going after what I call the target within the target. So each tumor has different components to it. There's usually 1 or 2 areas inside the tumor that have the most aggressive behavior. We can see this and measure it on MRI, able to aim the needle through that area. Also gives us the best genomic. There are a number of papers published on this saying you have to hit the target. If you're going to do tissue-based genomics, you've got to aim at the proper target. So there are a number of other strategies to do MR-targeted prostate biopsy. One is cognitive fusion, in which the person performing the biopsy looks at the MRI, they do an ultrasound, and they aim the needle at the area that they saw in the MRI. Then there's MRI ultrasound fusion, where the MRI is imported into the ultrasound system, and overlaid on top of the MRI. And so that target is able to be aimed at using 2 imaging modalities fused together. And then there's what we do, which is the MRI-guided in-bore biopsy. In other words, the patient is inside the MRI scanner. We take some MRI images, we localize the tumor, we find the area that's most suspicious, and then we place the needle in under MRI guidance. And so the ways that these biopsies can be performed are like we do transrectally through the rectum. It could be transperineal through the skin between the anus and the scrotum, and it can also be done transgluteally, kind of through the butt cheek, with the patient laying on their tummy, and the needle goes through the gluteus maximus and into the prostate. So again, our goal is to get rid of poke and hope. And you could see from these images, I've got a side view here with a needle guide in the patient's rectum. The prostate gland is right here. And we see an axial image with the patient sort of sliced like a loaf of bread. You've got the right hip over here, the left hip over here. This is the patient. This is the front of the patient. Here's the prostate gland. We have special software that lets us aim at the tumor. So we have a trajectory that's spit out by a computer, and we go in the room and we can angle a device that holds the needle guide in the left, right, front, back, and head foot directions. And this is what lets us put the sampling trough of the needle right through the worst looking part of the tumor. Once that specimen's collected, it goes off to the lab. And this is what it looks like for the patient. We've got a Cecil B. DeMille cast of thousands in here. This is a training session, but you could see our patient's laying on his tummy. We've got the apparatus between his thighs. The needle guide is in his rectum. The urologist is here putting a biopsy gun in, and we take the specimens. It's a 5-minute procedure for the specimens to be collected. They go off to the lab, and we have results within 2 to 3 days. So one thing that we do is once the needle is in the thrown position, we take a picture of it. So this image of the needle inside the tumor is incorporated into our pathology report, and it's put right next to a photomicrograph. So literally in a court of law, it's indisputable where the tissue came from. So we presented our results of in-bore MR-guided biopsy with regard to major complications at the AUA in 2017. And the problems that we run into with systematic trust biopsy, like rectal bleeding, 2.5%, hematuria, 0.4%, urinary retention, 0.2 to 1.7%, urosepsis hospitalization, 1 to 3%, and 30-day mortality greater than 0.4%. So these numbers are concerning. And when we do the less invasive, minimalistic approach with MR-guided biopsy, we have 0% bleeding, less than 1% hematuria retention, hospitalization, and no mortality. So there are attributes to in-bore MR-guided biopsy over trust biopsy. Our minor complication rate for uncomplicated urinary tract infection was 0.5% compared to 2 to 3% with systematic biopsy. And again, these results were presented at the American Urological Association in 2017. So the problem with transrectal ultrasound-guided biopsy is largely attributable to the throw of the needle. You've got about a 2-centimeter throw that can only reach so far. So here we've got this man with a 5-centimeter lesion on the anterior part of the gland that no matter how many times you biopsy him, you're going to miss it because of the length of the throw of the needle. It's just not. So we have a little analogy here. You know, this is Ying Mao Ying. He's a famous basketball player. He's like 1 million feet tall. And then here you got little Kobe Bryant. He looks like a midget. And he was a big guy, but he looks like a midget next to this dude. No matter what, he's never going to get the basketball. So that's kind of what the thing is with the trust biopsy. You're just not going to reach it in far anterior lesions and in lesions in large glands. So our colleagues in the Netherlands did a really good comparison of systematic biopsy and MRI targeted biopsy. And what you'll notice is that in high-grade cancers, MRI outperforms random biopsy like by a factor of 2. So you don't even need a p-value to look at these and see that, you know, for indolent cancer, they're about the same. MRI outperforms it. Intermediate grade, MRI still does better, but for high-grade cancer, MRI far outperforms transrectal ultrasound guided biopsy. And they say culture eats strategy, and I like to quote Upton Sinclair, you can't incentivize a man to understand that for which he's paid to not understand. So we've got two camps here. We've got radiology, which is a bunch of imagers. We've got urology, which is a bunch of surgeons. And we like them to hold hands and sing Kumbaya, but that wasn't possible 11 or 12 years ago. It's only recently that multidisciplinary teams have been formed so that we can work together to take the best of both worlds. Because in radiology, the imagers control the MRI and the imaging expertise and the MR-guided inboard biopsy. In urology, the urologist controls the patient. They have the prostate cancer expertise, and they do the MR ultrasound fusion biopsy. But let's take a quick look at the number of countries in the United Nations and point out that 170 out of 193 were invaded by Britain. So radiology has slowly been making a footprint and holding hands and singing Kumbaya with urology to do the very best for our patients. The most important thing was the addition of multiparametric MRI, whether we're doing ultrasound fused biopsy or cognitive fused biopsy. The addition of the MRI is the component that is the game changer. So there's lots of different fusion techniques out there. Your urologists have access to all of them. They're made by various vendors and have, I would say, probably similar performance as it relates to specimen acquisition and grading and staging. And I've worked with a number of these systems over the years, and they're all equally good. So there have been a number of papers published talking about the comparison of a fusion ultrasound-guided biopsy. Clearly it's better. MR targeting diagnosed 30% more high-risk cancers than systematic biopsy, and MR targeting diagnosed 17% fewer low-risk cancers than systematic biopsy. So it's a good pathway. So 30% fewer patients undergo any prostate biopsy after MRI-based clinical pathway, fewer core biopsies per patient, which reduces morbidity, fewer complications, improved quality of the biopsy cores, both in terms of histology, Gleason score, and genomic results. We detect more clinically significant prostate cancer and less clinically insignificant prostate cancer, improved Gleason grading and in the setting of active surveillance, and improved clinical staging, and it's certainly very cost effective and paid for by most insurances. So if you're in a situation where you've had trust biopsy but never had an MRI, you are in an ICD category where you can approach your primary care doctor or your urologist and ask for an MRI to get into this MRI-based clinical pathway. With that, back to Dr. Feller.
Thank you, Ms. Greenwood. So we're going to transition now from everything we've talked about up to this point with regard to the screening serum PSA, the multiparametric MR, and targeted biopsies is all standard of care and part of societal guidelines and clinical pathways at this point. What I'm going to talk about now is more in the translational medicine space, and this is the opportunity for doing focal therapy for prostate cancer to have equivalent oncology control is the goal, whole gland therapy, but to minimize the functional effects associated with whole gland therapy. So we're going to talk about a program that we've had going on for a decade here at Halo Diagnostics. It's outpatient MRI-guided laser focal therapy. Here we're using highly targeted heat to destroy the cancer tissue within the prostate gland. We do this in an outpatient setting. We use a real-time MRI guidance so that we can destroy the tumor, but at the same time, we're able, using real-time temperature maps called MR thermometry, to protect the critical structures around the cancer that we don't want to destroy. So we don't want to damage the rectal wall, we don't want to damage the nerves that control erectile function, and we don't want to destroy the little muscle that keeps you from having to wear a diaper the rest of your life that's called the external urethral sphincter, which if it gets destroyed, results in urinary incontinence. MR-guided laser focal therapy. As an update, I'd like to provide you with the results of a phase 2 clinical trial that we have been involved with that were 10 years of follow-up at this point. We're approaching 200 patients that have entered this IRB-approved clinical trial. About 85% of the patients are treatment naive, meaning they had previously had no treatment for their prostate cancer, and 15% of these patients are salvage patients, meaning that these patients had had some other definitive type of therapy for their prostate cancer, but that failed, and they came back to see us for MR-guided laser focal therapy. This is what we call true focal therapy with lasers, so our goal is to eliminate what we see with MRI, plus put a 1 centimeter margin around it to reduce the chance of the prostate cancer coming back. You can see the minimum age of patients we treated is 44, the maximum age 87, and the mean initial serum PSA about 7.5, which decreases to a mean of about 3.5, about a 55% drop following the MR-guided laser focal therapy. If we look at this pie chart of the age range of patients that we're treating, notice that most of the patients are in the 60 to 70 age range, 43, 15%, 50 to 60, only 2% in the 40 to 50 range. But notice about 7% are older. These are patients in the 80 to 90 age range. And the reason for that is because this outpatient procedure is so safe and the cost is less than half the cost of whole gland therapy, we can approach older patients to improve their quality of life so that hopefully they die of something else, maybe a stroke of a heart attack, with their prostate cancer, but not from it. So with focal therapy, even older patients have the potential to be treated. This is the tumor location. It turns out there are different zones in the prostate gland that we can see with MRI. About 3/4 of the prostate cancers are in the peripheral zone, which is the outside of the prostate gland, about 1/4 in the more central area called the transition zone, and only about 5% in the central zone, which is in the base of the prostate gland up near the urinary bladder. The Gleason score, which is the most important biomarker and a measure of how aggressive the prostate cancer is, you can see that most of the patients who were treatment naive, meaning that had no prior treatment before, about 60% of them were intermediate risk, which is a Gleason score 3 + 4 = 7. About 15% are 4 + 3 = 7. We have some low-risk cancers that are Gleason 3 + 3, also called grade group 1. About 1/3 of the patients we've treated with MR-guided laser focal therapy fall into this category. But these are Gleason 6 cancers that are MRI visible and are large volume, which are much more likely to become clinically significant over time than the ones that are MRI invisible and are low volume. If we look at the PSA over time, in the 12 months following the MR-guided laser therapy, about 39% drop in all patients, 37% in the treatment-naive patients, and about 60% drop in the PSA in the salvage patients. Notice the PSA doesn't go to 0 because we leave the rest of the prostate gland behind, which will normally make PSA. So normal prostate tissue still makes PSA. Sexual health information and looking at patients 1 year out after MR therapy, we've seen no statistically significant erectile dysfunction. If we look at a mental health questionnaire, no statistically significant difference 1 year out from MR-guided laser focal therapy, showing that no mental health issues develop as a result of this type of treatment. We do a biopsy at the treatment site in all patients at 6 months, and then they get yearly MRIs, and we biopsy anything that pops up over time. And at 10 years, about 21% of our patients have clinically significant marginal recurrence at the treatment site, and about 4% have clinically significant prostate cancer recurrence outside of treatment site. So if we summarized our phase 2 results with 10 years of follow-up using outpatient MR-guided laser focal therapy, we see that clinically significant in recurrence rates, so marginal recurrences, are about 21% actually at this point, and new foci of cancer that are outside of the treatment site pop up in about 4%. Because we use MRI-based active surveillance in all these patients, we pick these up, we biopsy them under MR guidance, and over 90% of those patients with a recurrence have actually elected repeat focal therapy. Importantly, we have no statistically significant erectile dysfunction and no significant incontinence that's developed in these men at 12 months. Only 6% of our men over those 10 years have had to be converted to whole gland therapy like a radical prostatectomy. So 94% have been able to avoid whole gland therapy, and the associated, which are erectile dysfunction in up to 50 to 70%, and urinary incontinence in up to 15%. Our metastasis-free survival is 99%, and our prostate cancer specific survival is 100%. That means that less than 1% of our patients develop metastatic disease in those 10 years, and no one in our clinical trial of those almost 200 men has died from their prostate cancer. So our oncology outcome is very, very good. In almost 80% of the patients, the very first treatment with MR-guided laser focal therapy, we have adequate cancer control. In the other 20%, as I mentioned, they elect, most of them, over 90%, to just have repeat MR-guided laser focal therapy. From an oncology control standpoint, using MR-guided laser focal therapy compare very favorably to the biochemical recurrence rates or failure rates for radical prostatectomy and for radiation therapy for intermediate risk prostate cancer, so Gleason 7 disease. There's a 20% biochemical recurrence rate at 5 years and over a 30% recurrence rate at 10 years for radical prostatectomy and for radiation therapy. So MR-guided laser focal therapy has very, very similar oncologic control, but the great story is that we don't have any of the side effects. So the quality of life and functional outcomes are much better. So why do we choose laser over other energy sources? Because it's very safe and precise, and because we can do it in an outpatient setting. Patient walks in, walks out. There's no anesthesiologist, no general anesthesia. We talk about being able to sculpt a therapy because it's so precise. The reason it's precise is the transition zone, which is the difference between where the tissue is irreversibly damaged, where we're trying to destroy the cancer, and where there's normal, viable, living tissue is only a millimeter with laser. So it's very, very precise. Other energy sources, that transition zone is much thicker. So let's see here. We kind of lost the slides, but actually this is actually a good point for that. At this point, we're going to jump and just summarize the take-home message from what we've talked about today. And that is that in 2020, getting a screening serum PSA with a baseline between 40 and 45 is very important. And then yearly after the age of 50 up to 75. And the reason for that is that we now know that it improves the survival from prostate cancer 30%. If you have an elevated PSA, don't just get a random transrectal ultrasound guided biopsy. You need to get a multiparametric MRI first before any biopsy. And then based on the results of that, if that's abnormal, then get an MR targeted biopsy. Finally, if you do have clinically significant prostate cancer that's documented with your biopsy, you need to get a multidisciplinary consult with urology, radiation oncology, and even with interventional radiologists to consider your treatment options, whether it's whole gland therapy with radical prostatectomy or radiation therapy, or the emerging role of focal therapy like MR-guided laser focal therapy, which has similar cancer control at 10 years, but none of the side effects. So with that, I want to really thank you all for your attention. Thank Dr. Herz and Ms. Greenwood for their contributions, and open things up to the question and answer part.
Thank you, Dr. Herz, Dr. Feller, and Ms. Greenwood, and to Halo. That was a wonderful overview. Really appreciate all of that great information. We do have a couple of questions that came in, and I know we're running short on time, so a couple of them are actually similar in nature, but to piggyback off of the insurance point that Ms. Greenwood mentioned, we do have a couple of folks on who have Medicare, and we're wondering if laser focal therapy is covered by Medicare, and then if you could speak a little bit more on the general insurance coverage, that would be wonderful.
Yeah, so right now, the MR-guided laser focal therapy is not covered by Medicare or commercial insurance, but there is a roadmap currently in place for that now that we have the data and the studies, and that's being published over the course of the next year in peer review literature. We're working with a consultant in one of the vendor companies, actually the consultant's based in Washington, D.C., to get a CPT code for this procedure, which will then provide for reimbursement by CMS with the commercial carriers then to follow suit. That time period will probably extend, the timeline looks like, into the first quarter of 2023 to get insurance coverage for this particular procedure and a Category 1 CPT code.
Great, thank you. And then bouncing back to the beginning portion of the presentation, we have a couple of questions about just general PSA testing over time and advancements. So can you speak a bit to that? Are the PSA test results, in 2020 a bit more accurate than they were 20 years ago? Have there been significant advances in that regard?
Yeah, I don't believe so. I think they're pretty much the same as they were. The difference, though, is because of our utility and because we have much more experience utilizing it, we're able to interpret PSA tests a lot better. Not just, as I mentioned, not just as a point on a curve, but as several points on a curve, what we call PSA velocity. So what PSA is doing over time. But we also know that PSA tests become less accurate as prostate cancer becomes more de-differentiated, as the Gleason score goes higher. So for example, with a Gleason score of 9 or 10, we may find that the PSA tests are actually pretty normal. And then we have to look elsewhere in terms of trying to find the prostate cancer early enough to make a difference. That becomes a little difficult. So we've learned a lot over the last 2 to 3 decades using PSA testing, and I think that knowledge has helped us interpret PSA testing much better. And I think that's the difference from 20, 30 years ago.
Great, thank you. And then I think we just have time for one last question. So can you speak to whether or not this type of therapy is appropriate for someone who has already undergone treatment such as radiation?
Yeah, so it's a great question. So the salvage limb for our trial is extremely encouraging. We basically have treated men that have failed all different types of therapy. So radical prostatectomy, radiation, other forms of focal therapy, including cryotherapy, HIFU, other laser, proton beam radiation, prostatectomy, brachytherapy, so seed therapy. basically any patient who has biochemical recurrence, meaning that their PSA went to 0 or near 0 and starts coming back up. Almost all of those patients have recurrent prostate cancer. Those patients need a multiparametric MRI of their prostate, and they need an Axeman PET CT or a PSMA PET CT. The multiparametric MRI will show whether or not there's a local recurrence in the prostate gland or in the prostate surgical bed. The Axeman PET CT or the PSMA PET CT will show whether or not there's lymph node metastasis, bone metastasis, or distant metastatic disease. That helps to decide whether or not the candidate's a patient for focal therapy. If there is locally recurrent cancer confirmed, which can be also confirmed with an MR-targeted biopsy, either in-bore or with fusion, those patients are a candidate for MR-guided laser focal therapy. In our salvage limb, the same facts are still present. The salvage men had no increase in erectile dysfunction or incontinence that's statistically significant following their salvage laser therapy. And their oncology control, we've had no patient die of their metastatic disease while they've been on the salvage therapy limb of our trial. So it's very safe, outpatient performed, and is also part of what we're pursuing a Category 1 CPT code for.
Wonderful, thank you. And unfortunately, we're out of time for questions, so I apologize if you asked a question and we were unable to get to that.
Shelby, you can send those to me by email, and we'll be happy to address them for you.
Thank you so much, Ms. Greenwood. We will do that. Thank you very much for that.
You're welcome.
I want to thank our sponsor at Halo Diagnostics once again, Dr. Herz, Dr. Feller, Ms. Greenwood. What a wonderful presentation. So informative and very exciting for our patient community. So thank you so much. And with that, thank you. To close our webinar today, I'd just like to very quickly, I know we're short on time, highlight Zero's patient support programs. We have several coming up, several events coming up. You'll see on this slide a town hall coming up on November 10th, another webinar coming up on November 18th, and then last but certainly not least, registration is now open for our virtual annual summit, virtual this year, unfortunately. A really exciting February to 28th, March 4th event where we will cover a variety of topics over a handful of days. So please register at zerocancer.org/summit. We're hoping to get 1,000 registrants this year, taking advantage of it being virtual in this crazy year. And I would also like to quickly highlight a couple of patient support programs that Zero offers. We have Zero 360, which is a comprehensive patient support program. We have case managers on the line ready to help patients navigate insurance and stress and emotions, financial burdens of a diagnosis, all free of charge. We have prostate cancer testing, screening locations available to you on zerocancer.org. So please take a moment to look into that. We also have a handful of peer-to-peer support programs, our Zero Mentor program, our Zero Caregiver Connector program matches caregivers and patients with those who want to receive support. So these peer-to-peer programs are instrumental in assisting patients navigate their experiences and share their journeys with others to provide that support. And then lastly, we have Zero Connect, which is a closed Facebook group for patients, survivors, family members to come together and network and support one another during a diagnosis and beyond. And lastly, I want to thank everyone once again for your time, for being with us today. This is the conclusion of today's webinar. And as a reminder, we will email you with a link to the recording as well as a short survey And the short survey will also pop up as we close out the Zoom presentation. Please provide us with your feedback. We use these surveys and those evaluations to better inform our patient and caregiver community, and it helps us to build better programs and understand the needs of our patients and caregivers. So thank you for your time, and our webinar is now concluded.
Thank you.